Okay, so welcome to this month's Health Council board meeting. And for introductions, I'll be asking you to just type your name into the chat box, and that will be our introduction. Is there any public comment? I don't see a throng of public on the here. Dr. Swanson, I think you're the closest to public that we have had for a few months. So if you wanted to make a comment, you can go right ahead. But so action items and approved consent agenda. Have people reviewed the action items? They're basically the consent agenda and the written reports. Does any need to be called out, or can we have a motion to pass them?
I move we approve the consent agenda.
I'll
as
second.
written.
Okay, Eric first, Linda second. All in favor, signal aye in some way.
Aye.
Those opposed? Okay, it passes. Ms. Mills, patient story.
All right. It's a long story why I'm doing the patient story, so we're just going to leave that at that. But so what we did is we actually chose one of our COVID mini grants for the patient story today. And the mini grant was titled COVID-19 Food for All. In June of 2020, a request came to the Health Council to partner with Seed to Table Oregon. The request was to supply fresh produce to overwhelmed food banks and sisters. At just 3 months into the pandemic, the community need for food banks had already doubled. Our COVID mini grant program allows up to $5,000. Seed to Table fronted $10,000 of other funding to acquire over 4,000 pounds of fresh produce on top of what they would normally have donated in a year for families struggling from July to December of 2020. This food was provided to families at 50% and sometimes 100% off the price based on need. A total of 298 families benefited from the weekly access to fresh produce. When Seed to Table surveyed 75% of all families who visited the food bank, they found that in every single recipient said they had increased their vegetable consumption by at least 1 serving per day. 98% said the availability of produce helped increase their family's financial and emotional resilience during the pandemic. Additionally, 79% said the experience of picking up produce and interactions with the community gave them an increased sense of belonging. So I thought that you might all really enjoy that. And we have hundreds of stories like this. Just as an announcement, so folks are aware, we are closing our COVID-19 mini grant process on March 31st. And going to refocus on the long-term needs of the community.
Are you good? Are you hearing the radio now, or what are you hearing?
We're hearing you, Divya.
Hi, I'm trying to figure out if I'm muted or not.
Well, you're not
Well,
muted.
you're not.
Okay, all right.
Okay.
So I have a message that Divya is driving across the pass. So and is calling in. And so if we hear a scream and a screech and a crunch, we know driving conditions were not great. Okay.
Thanks, Rick.
I believe in you, Divya. And I see Megan Hayes has joined us also, so good, and Gary's with us too. To the governance portion, Donna Mills, it's on you again.
I'm still up. So before I get to the actual topic there, I did want to take a moment and just update everybody on the fact that our legislative council number has been upgraded to a Senate bill number. As you'll recall, we are currently working on what we currently have is Senate Bill 648 and removing the sunset provision as well as the reporting requirements in this session. We now are Senate Bill 741. Yesterday, we were referred to the Senate Healthcare Committee, and soon we will be getting date and requirement for testimony. So if anybody is interested, I'm taking a nice long list of anybody that would be willing to testify alongside of us. As probably most of you know, that you don't get a lot of notice that that's coming. So we are waiting and very anxiously waiting to hear when that's going to be. So that's very exciting. I wanted to actually give a shout out to Linda Johnson and Tammy Bainey for their assistance in this process. It's been pretty exciting and I'm learning a lot in this space. So now I will get to my agenda item. So I'm going to have my projection person put up. Could you scroll to the bottom of that document, please? Keep going, keep going. There you go. Whoa, whoa, beforehand. Perfect. So last month we had some conversation at the board about finance committee and communicating with the board whether or not the CCO was actually tracking to budget and how would they know if they weren't tracking for budget. And the other piece of that being whether or not we looked like we might head into a recapture situation, which would of course mean that the CCO was not projecting that they were going to make their 2% margin. So I presented to the finance committee last week an idea of adding this information to the COHC financials that you receive in your monthly packet under your consent agenda. It'll be bigger than this. This is just an example. But if for the current year P&L budget variance, if it is greater than 7%, it will trigger a report to the board, which to me would look like we would actually probably pull this document out of consent, put it in live agenda and have a conversation. Of course, we have Megan Haas, who is our chair to the finance committee, and either she or if appointed by her, I would report out on that find. And secondly, if any other condition triggers a recapture environment, and when I say other condition like retro changes or anything else that would affect the P&L, the profit and loss, if we would trigger a recapture environment, then that would also be reported to the board. It could be an and or. But I just wanted to bring this to the board. The finance committee has recommended this for adoption by the board, but I wanted to put it in a place where it would be seen, and that if either of those boxes or those yeses are circled, once I make it nice and pretty, that again, then this would be moved to the open agenda for discussion. Just looking for feedback, or if does that sound good? We can try it.
Is this something, Donna and Rick, that the board needs to take formal action on if the finance committee is referring it to us?
I don't think so. Rick, do you have a different opinion? It's a recommendation to add it to a particular report. That doesn't seem like it would require a vote.
Yeah, I think it can be, Linda, you can add it to as a policy
Mhm.
rather than a need for board action, right? So I think it would be, from a governance perspective, just best written in as policy and procedure.
Right, and then when the board adopts the policy book, it's
And
included.
it's built into that.
Where that would show up in the policies manual would be in the monitoring that the board wants to do. So you're right, Rick, it's a perfect area for the policy side of it.
Right, because then if you want to change the amount or, all those other little course corrections over the years, it doesn't have to be a full debate at the board.
Right,
Um,
I agree.
Okay, great.
Okay.
Good question. Any other questions about this? Groovy. Ms. Neugebauer, you are on for the CCO 2021 budget.
Exciting stuff. Thank you. I think someone's projecting on my behalf. Is that correct? Great. Thanks. Okay, so I just wanted to take a couple of moments to talk about what the process looked like this year for the 2021 CCO budget approval. This will be a vote for you all at the end of my talking here and your discussion. And I have some specific items that you'll be voting on, so try to make it super simple in a not so simple process. So please feel free to ask any questions, of course. I just want to start out a little bit with process and then some components, and then we'll go to the voting pieces. So late last year in 2020, November, specifically at the November Finance Committee, we showed up, Pacific Source presented some budget assumptions. So things that we knew would be impacted regarding things like membership, revenue earned claims, for example. We shared that information with the Finance Committee and then had the first draft of the budget for 2021 shared in that December meeting. Lots of discussion ensued. I have this on the later slide, but there was concern from the Finance Committee about not meeting a 2% margin from, again, our budget assumptions and putting forth, really all the information that we had at the time. So in the December and the January meetings, we had lots of discussions about how we might get to that margin. And some of the things that changed in January were that Donna joined the contract negotiations for the shared risk arrangement, which includes COIPA, St. Charles, and the hospital system, and also the community mental health programs in all 3 counties. So Donna joined those negotiations because there were a lot of discussions around community investments and also COHC having a stake in the budget as well. And then we also had lots of discussions around some cost changes that could potentially be made to that shared risk arrangement, which there were many discussions about, and we made lots of adjustments there. In the February meeting just last week, the Finance Committee recommended board approval of the budget with some additional reporting, which I'll talk about in the next slide. Thank you. So I kind of said this already, but so the 2021 budget currently does not reflect a 2% margin. That was a concern of the Finance Committee. We talked about a number of ways that we could either get closer or meet that margin or even go over that margin. And the recommendation, there's a couple votes here, but the recommendation from the Finance Committee that your board of directors will need to approve is that they recommend approving the budget with also some additional tracking, which is really looking at 2 different budgets to actuals and tracking them side by side. So the first budget would be the one that we originally presented in that December meeting. Just one note here that there are many, many line items, of course, in that budget, but the one that is most notable here is that our budgets include just a 70% QIM performance. So typically we have, we usually get 100% of QIM performance or even more with challenge pool funds in the quality pool. But conservatively, we budget 70% and then make up for that if we have better performance. There has been one year where we have gotten 80%. And so that's a target that we won't know until June of the following year. The second budget that we'll be tracking for 2021 includes assuming 100% of that QIM performance. Also, some of those changes I mentioned in that shared risk arrangement and some of those adjustments that we've made. And then also putting a cap on the 1% of RIP funds that go to the COHC. And for folks that may have forgotten or are not as familiar, every month we are paying for operating expenses, of course, for the Health Council. That's been going on since day one. But as of 1/1/2019, with the JMA amendment, we have also been giving the Health Council 1% of monthly revenue from the CCO to make RIP investments. That is also less the community benefit initiatives piece. So I know this is getting really weedy, but just wanting to be transparent. And I know folks at the Finance Committee are very steeped in this information, but happy to answer any questions you have there. If you go to the next slide, I'll tell you more about that cap and some of the other pieces. So the Finance Committee recommendation here for your voting today is for 2021 budget only. So the first is that cap on the COHC's 1%. The cap would be at $2.5 million. That's less the budgeted $370,000 for community benefit initiatives. A little bit on that, community benefit initiatives are a CCO requirement. They are allocated by our Community Advisory Council. And that's just a 2.0 2020 requirement, and then moving forward for the rest of our 5-year contract with the OHA. The Finance Committee, when the Community Benefit Initiative requirement came on board, agreed to having Pacific Source hold 10% of that 1% in our accounts to wait for the CAC allotment. So just a little bit of history there. So that's the first voting item, capping that 1% to 2.5 million. And I can tell you a little bit more that I think at the end of 2020, the number was close to 3 million, I think 2.9 something million dollars in 2020. That kind of ebbs and flows, of course, with membership and some other considerations. So these are kind of just budget estimates. The second piece is currently the quality incentive metric, or the quality pool funds, are set where when we receive those performance funds in June of every year, typically in June of every year, certainly not in 2020. But typically when we receive those funds from the OHA, this year currently the Finance Committee agreed to a 50-50 split, meaning 50% is going back into the global budget to pay providers, and the other 50% is at COHC's discretion, and within that COHC's 50%, there are 35% that goes direct to providers, 10% that goes to social determinants of health and equity funding, which is also a Community Advisory Council allotment, and 5% for quality and population health improvement projects that were administered by Pacific Source and kind of overseen by the provider engagement panel. The second bullet here is requesting it's saying revert because in previous years it has been a 60-40 split. So 60% going back to the global budget, and then the 40% in that other pie, which will be, not as round numbers this time. I have not done the math yet. So the second piece there is reverting back to previous years and having a 60-40 split there instead of a 50-50 split. And then the last piece is just, again, approving the tracking that margin on those two separate budgets, which we already have capability to do. So I will pause and entertain any questions, or if anyone on the Finance Committee wants to add anything to what I presented and what we've talked about for the last few months, please feel free.
Brad, I see you, but let me do a couple things. One is someone from a 447-6672 called in. Looks like a Prineville number. Can you identify yourself, or is that Muriel?
Must be.
No, it's not me. I'm on Zoom.
Okay. Okay, I'll try again, Kelsey, later. Then, where are you, Megan? Did you, as chair, did you want to add anything to the, Leslie's presentation?
Yeah, I'll say that it's been a really good process. If we remember last year, we were approving a budget that wasn't meeting the JMA margin. And I think there was some discomfort with the Finance Committee and the board. And then this year, we've worked really closely with the Pacific Source team to find a path to be able to get to that margin. And the Pacific Source team, along with the other partners, have, I think, been really thoughtful and creative in getting us to that margin with the second budget. And I really appreciate that Leslie and the team are able to actually report on and track both these budgets. So I think this has been a really good process with some improvements over last year as well. So.
And then, and I see you, Paul, too. And then just to add that the idea on the cap to the COHC 1% was using the advantage of the large run-up in membership that took the revenue that would be going towards COHC higher than budgeted. And so we took advantage of that as a one-time effort to plug a hole. So I think Brad and then Paul.
This is Brad. A couple questions. One is,
Uh-oh.
Can you hear me?
Sorry, we lost you for just a second.
You hear me now?
You start
Yeah.
over? Yeah.
Okay. Regarding the tracking of two different budgets, are you able to kind of concisely explain the difference between the two budgets? Is it on the income side or the expense side?
Yeah, I am. So there's a couple of pieces. Mostly it's around that difference between the quality pool budgeting. So if we're budgeting on one budget, we're budgeting 70%, which is traditionally what we do and very conservative. And the other budget is 100% of quality incentive funds. So that means, as a region, we need to perform very well on quality incentive metrics in order to receive 100% payout. So that's one big difference. That's about a $3.5 million difference there. The second is around a lot of these contract changes. So around on the expense side. So, mostly around claims, medical, behavioral health, et cetera, claim expenses. And so we have made some cost changes in the shared risk arrangement, which is where most of our expense is tied. And so those parties agreed to a handful of changes between the IPA and the hospital and the community mental health programs. Those folks and Pacific Source, all of those folks agreed to a handful of contract changes that will, have an impact. And then, of course, there's one piece that's eluding me, but I'll happily look it up.
Thanks.
So Brad, part of it is that we knew we had some process changes in there that we're building to try to impact the budget. And we wanted to see whether they were succeeding or not, or we were going to be in a big hole or not, so know that in advance. Paul.
One other.
Oh, sorry.
thing.
Sorry, I didn't have to open it to look, but the other part is the 1% change for COHC.
Yeah, just
Okay.
one other quick thing, Rick. I wanted to know what's the motivation to capping the RIP funding?
What we're doing there is there's been a dramatic upswing in membership. And so the revenue going in was higher than expected. And so and we have healthy reserves in the Health Council at this point. So it was simply not padding those reserves more and putting them on a one-time basis into the global budget. So that was the thinking.
Okay.
Just on that too, Donna, am I correct that in previous years it has been around $2.5 million, like in non-explosive membership years?
Non-explosive membership years, that's very definitive, yes. The fact that our budget, our 5-year forecast is built on receiving 2.5 million, because that has been pretty much the norm. Of course, with the lack of churn in 2020 and the addition of the folks that had become unemployed by no fault of their own that were able to roll onto OHP, that actually inflated that number. So it really is a if you will, a give from the Health Council to help in the global budget for 2021 only, to help mitigate the shortfall.
Okay, Paul?
Yeah, thanks.
Thanks, Paul.
Hi there. Appreciate the presentation and perspective. Sounds like it's consensus from the Finance Committee. Didn't hear a minority report. Were there some concerns that were expressed that the board might want to know about in putting this forward, in terms of a little worried about this, or long-term concerns if we do this, that would be good for us to know about?
Megan, you want to answer that?
I think that the main concern was not achieving the margin that was in the JMA, that led to this work and kind of collaborative effort to be able to bring a margin up to that JMA level as a second budget. I think that the 60-40 split wasn't the original recommendation coming to the Finance Committee, and then that was a discussion at the Finance Committee, and then a vote to add that, to change it from 50-50 to 60-40. But otherwise, I don't think there were other concerns. But anyone else from the Finance Committee?
I think and correct me if I'm wrong, but there is a concern that the expenses against the global budget have been going up faster than the rates have been going up from the state. And so we need to pursue strategies to, hopefully smart strategies, to figure out how to get that better in line.
I think,
If I might, sorry, Megan.
Go ahead, Donna.
I was just going to say, I think if I might add that also, and we're going to talk about this a little later in the agenda, but with the cost and use steering committee, and this last year with COVID and really trying to get our footing in what was going to be the most productive and effective at addressing those exact things that Rick spoke to, that we didn't have enough runway. And we still believe that we're on the right track with those, with our approach there. And again, we'll talk about that a little later in the agenda. But I just want to reiterate, and I know that Leslie, you have it here very appropriately, but this is just for 2021. There's no intention in rolling these things into another year. That the 60-40 will come back on the table at the Finance Committee as reverting back to what we had before. So we're really kind of following an anomaly of a year that, as hard as we try, we can't normalize that P&L. So COVID really jacked us up in lots of different ways. So I hope that's helpful.
Thank you.
And Kelsey, the 447 number is Seth's cell phone.
Awesome. Thank you so much for confirming.
Any other questions about the Brad?
Yeah, so I'm just want to follow up on that 1% cap, or the 2.5 million cap. So that's money going back to the community. So I hesitate to agree with that, capping that. So I'd like to hear, I'd like to hear more. I mean, is it just for this year, and is it only just for this year's budget because things are so bad at CCO? I mean, I'm just trying to understand why we would agree to cap money going back to the community. That's just that 1%.
If I might take a swing at this, Brad. So what has been earmarked for the community in our reserve currently covers everything we have promised to pay out for the rest of the RIP. And that is really predicated on a $2.5 million budget or revenue income to the Health Council on an annual basis. So by having that actually be increased, we were not actually withholding that from the community. And follow me here, because if in fact the CCO does not make their 2% margin, we, the Health Council, will be the ones on the hook for the recapture. So it's kind of almost like we can participate now with the rest of our partners and stakeholders in the community to make sure we make that 2% margin and protect that, because that protects funds going to the community, because otherwise that they're going to be shorted when we have to make sure that the CCO makes their 2% margin. So the fact that the budget for the RIP is safe and sound, and to Rick's point, we have reserve. That's why in this 1 year only, we are willing to make this gift. Is
Okay.
that helpful?
Yeah. Thanks.
These are good questions, very good questions. Any other questions? Okay, so Donna and Leslie, as I was tracking, we have 3 votes. Are you nodding, Leslie?
Yes,
Help.
I tried to make it very clear on this slide.
Okay. So I'm looking at that. Okay. So the first vote is what we've just been discussing, the capping the COHC percentage for this year only at 2.5 million. And welcome Commissioner Simolik and Commissioner Crawford. Good to have you here. You're right in time for a budget vote. So can I hear a motion supporting that?
I move that we adopt the Health Council's 1% RIP funding cap at 2.5 million.
Okay. Is there a second?
Second.
Gary Allen, I'll second.
We'll have Gary second it.
Thank you.
Since the Finance Committee would be presenting this, so it's better. Any discussion about the motion?
Is it possible to say for this year only? I mean, is that a needed add to the motion? I just would hate to think that we did this and then next year we couldn't change things.
Right, was
Was
that
it bad precedent?
Yeah, I captured that in Linda's motion just now. Mhm.
Okay.
This year only.
Yes.
okay? Okay, all in favor, signal yes.
Yes.
Yes,
Yes.
I'm still alive. Yes, this is Divya.
Okay, good. You're not in a ditch. That's a good thing. All opposed? And thank you, Commissioner Simolik. We got a yes on him too. And I'm hearing no opposed. Okay, good. Okay, so then the second vote is revert to the 60-40 split from the 50-50 split for the QIM funds. Do you want to try to explain that in brief 1-sentence summary again, Leslie, for the uninitiated?
Sure. So, excuse me, currently, the Finance Committee voted for quality incentive metric funds, so the quality pool funds, to be split when we receive these funds in June, to be split 50-50. So 50% goes to the global budget and 50% goes to the Health Council, which is then broken down into 3 areas. One is 35% going to providers, and there's a whole algorithm on how Donna pays those providers out. It's largely by population. And then 10% goes to social determinants of health funding and equity funding. That's a requirement of the OHA. That's a portion of our quality pool goes to social determinants of health and equity funding. That is something that we have had the Community Advisory Council allocate those funds for. And then the 5% left is for population health and quality improvement projects that Pacific Source implements at the oversight of our provider engagement panel. The Finance Committee, in an effort to have more dollars go back into the global budget to help this CCO budget and the shared risk arrangement, for example, asked that for 2021, it's saying revert because in previous years it had been a 60-40 split of 60% going into the global budget and 40% being at the discretion of the Central Oregon Health Council. So the Finance Committee asked that we revert back to that 60-40 split for 2021.
So this one would not be for 1 year. This is going back to what it's been.
Well, yes. So we've only had it 1 year at 50-50, and then it was a bit of a wash because the quality pool was a little bit moot. It'll still be for Q1 funds. That's, again, way more detail that we'll talk about at the Finance Committee. But the reason why the word revert there is because in all other years except for 2020, the Finance Committee has had the Finance Committee approved a 60-40 split. In 2020, they approved a 50-50 split, and now they're asking for 2021 to kind of go back to what it used to be. Does that make sense?
And it can be renegotiated every year. So it's not that hard to change. So can I hear a motion in support of this? Linda, if you want to complain that we never listen to you, you have to get off mute first.
Got it. Thank you. I move that we revert back to the 60-40 split for quality incentive metric funds.
I would second.
And Eric seconds. Okay, any discussion on the motion on the floor?
Just a point of clarification again, and I appreciate all the discussion around this and the history. So does this then put us in a position that we're going to be having this vote every year, or will this leave it at 60-40 unless we bring it up again and say we're going to do 50-50 again?
The second.
Okay, thank you.
Good question. Any other discussion? Okay, all in favor, signal yes.
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 Divya, aye.
And opposed? Justin, are you unopposed? Okay, Justin is an opposed. Abstentions? Okay, and Justin, did you want to explain the opposition vote, or are you just fine? You're fine, okay. And then 3, so then, well, there'll actually be 4 votes, Leslie, because then we actually have to approve the budget. So,
That's true. Good
so
point.
you know.
Touche, Rick.
So approve the tracking. Do we really need a motion to track margin on?
Perhaps this third one should have been approve the budget, and then we'll track it twice.
Okay, great. Well, why don't we do that? So given all that, can I hear a motion to approve the budget as presented? And we will, with the understanding that we will be tracking the operating margin in 2 ways throughout the year.
So moved.
Okay.
I'll second.
Gary seconds. Any further discussion? All in favor, please signal yes.
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 Divya, aye.
Opposed? Justin opposes. Any abstentions? Okay, here we are. Thank you for good discussion and good questions about the budget. Leslie, you're on for Q4 metrics.
Thank you. I don't know if someone's going to project the packet. It's on page 12, if that's useful for anyone that has a packet. I'll just get started. Thank you so much. So I'll just, for ease of scrolling, just go through this kind of top part first, and then we can jump down to the bottom. So again, these are our quarterly metrics, or really they're annual metrics. I'm giving a quarterly report. I typically give a quarterly report 2 months after the end of a quarter. Excuse me. So this is your Q4 2020 report. So for the months of October, November, and December of last year, there are a couple of caveats that I'll speak to on that. But we can just get started. Actually, we can get started on the quality and member experience side here. So a Q4 update, but also really kind of an annual update. Of course, everyone knows that there was an impact from the pandemic on the 2020 QIM program. Lots of changes at the OHA level. There were some early release funds in Q2 and then suspended withhold for the rest of the year. We are still expecting Q1 2020 funds to come in sometime in late June or early July. So more to come on that. But the big story here is that even though the pandemic obviously impacted the QIM program and many, many other things, we actually had pretty good performance in the region despite that. So the note here is even through the governor's closure in those handful of months, we as a region performed quite well on the QIMs. And the theory there is that, well, there's so much work, of course, that has gone into each metric in our provider offices. Workflows have been stood up and tested, and quality improvement efforts have been deployed. And so the thought is that we already are way down the road in the quality incentive measure and quality pool program, that it's just really built into daily work. So really proud to report on the region's performance there. And then then there's a very extremely bright story in the QIM program that the care that our postpartum women are receiving is at an all-time high, even during a pandemic. So that was really lovely to hear. Moving forward to 2021, there are just some minor changes in some of the metrics. One is around, oh, sorry, can you stay? I'm still on that first number one. Can you go up more? There, thank you. Just a couple minor changes in the 2021 program, QIM program. So the preventative dental metric is now, they're able to enable services to be performed in a primary care office. So there's a little bit of changes in that metric as well. We feel like that is a welcome change. And then there is one new QIM added to the 2021 program, and that is around limited English proficiency. And we already have had, it's a process measure, so we already have had many, many collaborative conversations with community stakeholders, lots more to come on this metric. And I assume in 2022, it will be a performance metric and not a process metric. So much more to come on that. That number 2 there around performance improvement plans, you can read through that. There are just a couple minor changes. This often occurs on the calendar year, so please read through those. And then the story on number 3, that TQS plan transformation quality strategy. In 2020 was the first year that the Oregon Health Authority scored our TQS projects plan. They scored every CCO's project plans, and we got higher than the average CCO score there. There's some room for improvement, of course, and so we're working to deploy the 2021 plan in the next month or 2. So if you want to scroll back up to the financial stability piece, still appear to be performing well in Q4 on the 3 metrics around ED utilization and all-cause readmission rates for the end of last year. And then the metric here in red around the CCO budget, is again around that margin conversation. I did note here that December financials aren't available. They actually still are not available, potentially available tomorrow. But this is based on November budget performance. So more to come. We have one more month of the year, and then of course to close out that year. 1 second. So what the margin was looking like in November was closer to 1.5% instead of that 2% that we're looking for there. You can scroll down to the next page and I'll speak a little bit on the CCO 2.0 requirements piece. The story on value-based payments is we have already implemented new value-based payments in behavioral health and hospital through the shared risk arrangement and adding SageView in patient psychiatric services to that value-based payment model. And we will be having conversations about how to implement a maternity care value-based payment model that will be implemented by 2022 as a requirement of our contract. If you scroll down to number 3 around traditional healthcare workers, the story here is really just that there's still a lot of education occurring with our providers. We also actually, part of that 5% of that quality pool funds for quality improvement and population health projects that were overseen by our provider engagement panel included quite a few trainings for peer support specialists, community health workers, doulas, peer navigators, et cetera. So we're really pleased to partner with folks on that kind of education. And then just that last piece, number 4, on setting up 2.0 funding streams. I think this is a little bit old news now. I mentioned about the quality pool funds for 2020 were paid out very differently. The Community Advisory Council allocated all of the Community Benefit Initiative and the Social Determinants of Health and Equity funds for 2020. That was a really exciting process to witness. And then there is a new funding stream that will actually, this supporting health for all through reinvestment or the share funding that we are still trying to wrap our arms around internally to get, there's a lot of financial requirements around how to come to that number and what that would look like in practice. And so hoping to get an answer on that before the end of this quarter 1, and then determining a process that will certainly involve the Health Council and specifically the Community Advisory Council. If you want to scroll back up to that last quadrant around CCO operations, our call center performance and our claims payment for timely and accurate payment are both working really well. It's pretty rare that those two operations are not operating well-oiled, so pleased to report that. And then this last piece here, number 3, is around our external quality review activities with the OHA. So this is our oversight body, of course, and the audits that they perform on us annually and also kind of regularly. They're now doing more of like a rolling activity with CCOs. And so we just received our final report from the 2020 audit. It was an overall score of 92 out of 100. We had 10 findings, and you can see listed kind of some themes of those findings there. So pause and answer any questions or entertain comments.
So just to remind folks, the point to these metrics is so that we have, as a governing board, some insight into how well functioning the CCO is with for its day-to-day operations as a CCO. So every year we agree to monitor some performance metrics with some benchmarks in there built in. So that's what this exercise is about. And does anyone have any questions or concerns or alternative realities to ask about?
Rick,
Actually, this is Iman. I had a question about the postpartum follow-up up at the top. Is that one of the 4 hospital follow-up metrics that you're referring to?
I don't know the. I don't know the. This is around pre and postnatal care. I don't know the QIM.
So it's probably
specification
the clinic-based performance rather than the hospital.
Yeah.
Okay.
That would be correct.
Thank you.
this is Linda. I have 2 thoughts. One is we're testifying before the legislature on why our model needs to continue. I think our performance, there's some really good stories in here about what a difference we make, and that justifies that request, I think, for continuation without a sunset for our existence in our model. And secondly, in terms of communicating to the public, again, who is the Health Council? What do we do? What is the CCO? There's some really great public stories in here about the success and what it means to everyday people. that I think we might want to think about doing a press release or working with the bulletin to target a few stories that would explain more and improve people's understanding of who we are and what we're about.
Okay. Other questions or comments? Okay, I don't think that takes a board action. So that was just a presentation for, again, our oversight process. So Dr. Swanson, you are on.
Thank you. Donna, I forget how much time I have. Can you remind me so I'm respectful of the time that I'm allotted?
We are way ahead.
20 minutes, young lady.
20 minutes, wonderful.
20 minutes, but we're way ahead of schedule.
But we're running ahead, so.
Well, I'd rather give you time back and off Zoom versus take more time. Michaela, are you bringing up slides? Thank you. Thanks for having me back. I think I know everybody here, but in the event that I don't, I'll just introduce myself. I'm Dr. Kim Swanson. I'm a licensed psychologist. My full-time gig is I'm the director of behavioral health at Mosaic Medical. My other gig is I've been the chair of the Pain Standards Task Force for the Central Oregon Health Council for 5 years now since its inception. So I think this is my 5th presentation to the board, and I'm always super grateful for the time. Next slide. It's been a year. I don't know that I have to say that out loud. I think y'all know that, considering you've lived through it with us. So I just want to give special thanks to Donna and I have had to develop a certain closeness to get through the last year, as well as Michaela, Aaron, and Kelsey to really shift and pivot to make operations of our mission, vision, and values for Pain Standards work. I really want to thank Pain Standards. We have had a really dedicated group of individuals, 2 of which are sitting on this board, 3, Divya, for a very long time, and really kind of plugged away at what we've been trying to accomplish. Next slide. This is a little sobering, but I can't, it's sort of like the thing we have to talk about though. The pandemic really did worsen overdose rates. So we had a 40% increase, and at one point we peaked at nearly 70% increase in overdose rates in our state. Most of those deaths involved opioids, but we are really seeing an increase in methamphetamines that have synthetic fentanyl. And just for your knowledge, about 20% of the methamphetamine has fentanyl in it. And people that are taking methamphetamine don't necessarily know that. There is a growing misconception within the communities that methamphetamine is the antidote for overdose, and it is the antidote for opioid use disorder. So there is a growing trend across the United States for people to use illicit stimulants, and the death rate associated with methamphetamine that has fentanyl in it has steadfastly increased over time. Next slide. So over the last 5 years, we've really stuck to a 7-point strategy, and we just really stick with it and go over it again and again. And as a reminder, number 1 is adoption and implementation of safe prescribing. We can't stop the flow of illicit substances, but we certainly can. We certainly have some element of influence and hopefully change the direction over iatrogenic substance use disorders and overdoses. Strong focus on education to, Brad, if it's okay, I'll answer your question. I got it though. Education to medical providers in the community. We believe in a foundation of measurement-based practice. We're a small group, so we have to know how to dedicate our time really judiciously. We wanted access to comprehensive pain management. We really heard our our medical providers early on in the opioid epidemic that you really had to have alternatives to opioids to be successful, harm reduction strategies, increased access to treatment, and public awareness. And Brad put a question in the chat: what number of people do those overdose stats represent? You know, I didn't dive a little bit deeper into that data, and I think it's a really good question. I'd have to go onto the PDMP website to look at some of that overdose data, Brad, to be sure if I could give you the demographic, and I don't have that today. I apologize.
And Brad, we know that that is underreported. Just
way underreported. Yes. Next slide, please. So I'm super grateful to y'all for approving such a generous budget for us on an annual basis. And we always pledge to be good stewards of that budget. So our budget for 2020 was $60,000. And spending as of November was well under budget at $47,303. And we don't anticipate to hit that $60,000. Next slide. We adopted the Oregon tapering guidelines. For those of you that may not know, this was published, I think it was March. No, when did this come out? Michaela, save me. Was it early 2020? Yeah, I had the good fortune of sitting as a behavioral health representative on this task force and was able to draft these guidelines. Feedback we've received from people around the state for the group of individuals that did this felt that this was a very patient-centered guide for providers and to give them tools and resources to know how to taper. Next slide. I'm not going to go into lots of detail about each of these slides. We will go through them. In education for this year, as a reminder to the board, we adopted the acute pain guidelines. So we shifted from chronic pain, which we still focus on, and added acute pain. And as part of that, we really had a group of community stakeholders through the variety of avenues for acute pain. And they really helped us. They helped us craft our learning events. So we did 5, we have done 4. We have one more learning event come up. We've done one for primary care, emergency department, immediate care, women's health, compassionate conversations. And then the ones coming up with lots of help from Gary is our dental and oral surgery, which should be happening in May. So we, in the 4 events that we've had, and they all pivoted to virtual, we had a total of 116 attendees. We were able to open up participation across the state. So we had some participants that were outside of the Central Oregon area. 70% of those attendees rated the events as outstanding, with the remainder falling mostly in the good category. And 80% across all educational events said that they learned something new. Each of these slides will go through greater detail. If you're interested in learning more about each of those learning events, you can go ahead and scroll. This will give you a specific data about that event for the primary care event. Next slide. The next 3 go through the next learning events with our speakers. And then the slide after that really goes through specific data that we collected on those 3 learning events. Next slide. Next slide. So considering we had to pivot pretty fast and learn how to put on virtual events, I feel pretty positive about the impact that we had, the number of attendees and the responses that they gave us. Our chronic pain dashboard is still active. I will say most people at PDMP have been commandeered to get data around the pandemic, and that makes total sense. But just as a reminder for what we are trying to develop, we're trying to do a new dashboard that includes chronic pain and acute pain prescribing. And so what we're looking for is really kind of a split panel, if you will, on that dashboard to use as communication to providers to always keep us kind of measurement-based practice of how we're doing and the impact we have as a result of the work that we're doing. So one of the things we're looking at in acute pain is the distribution of individuals by total morphine equivalent. Thank you for putting in, sorry if I'm saying jargon, prescription drug monitoring program. And that is the program that tells us what's been prescribed per patient across our state, the state of Washington, Idaho, and California. The average of refills for the first acute pain prescription and the fill for the opioid naive. The average opioid morphine equivalent. Morphine equivalent is a measure of strength of an opioid. We measure all opioids against morphine, and that just tells us how strong it is in comparison. The average morphine equivalent for chronic pain, the rate of chronic pain prescription fills per 1,000, and the rate of acute opioid refills per 1,000. And just for you all to know, what we're looking for in that morphine equivalent is a pattern of risky prescribing. What is considered a pattern of risky prescribing is anything that's over 90 morphine equivalents in a day. So that's why we want that morphine equivalent dosages. And morphine equivalent dosages just takes all these opioids and narrows it into one succinct way of understanding risk associated with it. Next slide. So I took this off of PDMP. Since the inception, you'll see that we've had overall across all of our counties an overall decline, which is exactly what we want to see. We've wanted to see this overall decline in the risky prescribing. So you're seeing across the counties that per 1,000 residents, that we are trending down in the risky prescribing of that 90 morphine equivalents per day, which is super exciting. We all get super stoked about that. It tells us that we're headed in the right direction. Next slide. So this tells you about non-tramadol prescribing in Central Oregon. So this takes tramadol out of the picture, and you still see that we're in an overall downward trend across all 3 counties. Next slide. But there's a concerning trend that I've been keeping my eye on, and I'm not exactly sure how it relates to the opioid epidemic. And this is also seen across the country. And I'm starting to see some journal articles out there that are alerting to me that outside of the scope of the Pain Standards Task Force, there's a potential another issue. And this is the stimulant prescribing across Central Oregon. You'll see Deschutes County is higher. We've been a perfect inverse relationship between opioid prescribing and stimulant prescribing. Stimulant prescribing has steadfastly been increasing across all 3 counties, with Deschutes County being the highest, and it's even higher than statewide prescribing. We're seeing this trend. Like I saw the article the other day saying, do we have another drug epidemic in the making? And so potentially, I don't know how this relates to the opioid epidemic. It may not, but we're seeing a concerning trend in increase in stimulant prescribing across the nation, but especially here in Deschutes County. Next slide. This last year, we were lucky enough through RIP funding to be able to award a grant to comprehensive pain management. Right now, that's in a virtual platform, and it's available to any patient throughout Central Oregon. The Pain School Online teaches patients specific skills to cope with chronic pain. And it has peer support, it has movement, and it has a core component of group therapy. In addition to that, they're piloting right now the addition of virtual telepain. Thank you, Patty, for that question. So stimulants are going to be Adderall, Ritalin, Adderall, Ritalin, oh, physician save me. I'm forgetting one. Divya, what's the one I'm forgetting? Adderall, yes, thank you, Visceral. So those are the drugs that we're talking about. Okay, so in La Pine Community Health right now, they are piloting a program where we're going to do something similar to what they did in the state of Texas, because pain specialists are so few and far between. They really initiated physiatry for chronic pain online with a pattern where you'd have some in-person visits. So they're starting to pilot this in La Pine with Dr. Paul Coelho, who works at Salem Health, and he is a pain specialist. And if all goes well, we anticipate spreading that throughout Central Oregon so that we have an additional resource for chronic pain care, a full spectrum. Next slide. So every year we put a naloxone community grant out. And so we've put more and more out there, but there's also been more and more need because we're seeing a systematic rise in overdoses across the region. And so the total doses deployed have been 48. And all Narcan administered by formally trained law enforcement. Naloxone is the overdose reverse drug. It's the only thing that will save people from an overdose for opioids. It will not save you from an overdose from stimulants or alcohol or benzodiazepines, but it will reverse an overdose from opioids. And that includes opioids that are illicit, like heroin, for example. The diagnoses that are, Brad Porterfield put a question in the chat. What diagnoses are driving the increase in stimulants? I think primary care will easily attest that we've had an increase of people coming into primary care asking for assessment for adult ADHD. That's one of the primary drivers of that. And that's what the research is indicating across the country as well. So with naloxone, we also have deployed this to syringe exchange. So we're getting it right into the hands of people in the community that are at the highest risk. And those community members are the least likely to call 911 if they're in trouble and they need help. Next slide. Oh, I can hide my age in so many ways, but not through my eyes. So pardon me, that print is very small for me. We distributed to community partners. 11 community partners applied for the naloxone grant, and we provided extra funding to accommodate the need in the community. The total cost of Narcan for our 2021 was $29,700, and total Narcans distributed between Deschutes, Crook, and Jefferson is 390. So what is the number what for Bend PD? Good question, Michaela and Aaron, do you remember how many we distributed to the Bend PD? It was quite a bit, because we also distributed Patty to Redmond PD as well. So it was across. Michaela, do you remember?
I'd have to look.
Yeah.
They did receive the RFP.
Okay. Well, we'll look, Patty, but we did distribute to law enforcement across all three counties, at least 2 counties. Next slide. So Central Oregon has an overdose crisis response. This was actually birthed out of pain standards. We got grant funding a few years ago. We drafted what the community standard would be. And then we had our first meeting, and it's really been turned over to public health. I'm not going to go into a lot of details about that, but no, we are working towards coordinated, systematic overdose response. Next slide. You can see these are the members. And I think what's really cool right now at this stage, we were really in the birth stage of this, but we now have a way to, correct me if I'm incorrect on this, we have a way for community surveillance now. And we're able to determine clusters of overdoses across all 3 counties. And we have incident command that is able to respond. Next slide. Next slide. Next slide. That's lots on the overdose. Yeah. And Rick is here to attest. We have, so this was a long time coming. Rick, how long did we work on getting folks into the ED? Probably as long as I've been a chair of the committee. Yep, he's shaking his head. So it's really exciting to see this last few years. We now have substance use counselors embedded in all of our ER departments across the region. And so what's really exciting about that is it fits with other successful models of care around the country where you can really capture people early on and get them engaged into treatment in a rapid fashion so that we're preventing a recidivism into the ER and actually changing the trajectory of people's lives. Next slide. And then the last part about this is we put on so many events and we do, thank you, Aaron. So Patty, Ben PD received 30 doses for the 2020-2021 grant year. And so we film all of these, but you can't necessarily get CME as a provider unless you go to the event. And we thought it would be just a really great idea, since we invest a lot in recording these events, to put it out for that they could just get CME anytime they were able to view it. And so we're working with OSU to do something that's called Enduring CME. Kelsey really brought this to the table and we think it's a fantastic idea. And what's cool about it is this is a little innovative for them and they see us as being a little innovative. So we're their first crack at this to see if we can pilot it and have enduring CME of our events over time available to any medical provider in the community. Next slide. That's it. That's what I've got for you. That's all we've been doing in the pandemic. That's it. Yeah. Any questions for me other than what you've asked?
So any questions from the board?
No questions, just a comment on how impressed I am about the work and how appreciative I am to know what's going on day to day in the community and what a difference your team has been making.
That's very kind. Thank you. I will be sure to tell them. Thank you, Linda.
Brad.
Hey, this is Seth
Yes.
from Crook County. That was a great report. I'm sorry to interrupt. I've got to go to a meeting and do some other stuff this afternoon, but I wanted to tell you that I talked to the high school and the school district, and they were really, really appreciative of getting the grant. So they wanted me to pass that along to you.
Oh, thank you, Seth. That's very kind. I'll pass that on to the group. Brad.
Cool. All right.
Yeah.
Have a great day.
Thank you.
Hey, can you hear me?
Yes.
Yeah, I'm curious what's behind the increase in adult ADHD? Like, what's the drive?
Yeah, I am too. I'm not sure. And in truth, I saw this spike and I started to do a lit review, and then I haven't had any time on my schedule to go any further. I don't know, Brad. It is really it's a curiosity to me. I'm not sure what's behind it, but it's concerning that it's risen that much.
And Brad, there's various psychiatric diagnoses that I just see over time that are poorly diagnosed. And so you end up with these trends going along. A few years ago, everyone was bipolar, and it's like, to hell they were. So there's these fads that happen. And, you know, when we get these clients and you take a look at the quality of the diagnosis, it's, you know, really quite poor oftentimes. So, and I've seen this in one form or another, one diagnosis or another throughout my career.
And I do think that's part of it.
What's the
But
driver? I don't know.
I don't know the driver. And what's concerning is that, you know, we're dealing with, addictive substances over time. And we've had such a dedicated focus around opioids that I think providers have really gotten the message about what, you know, harm reduction, safe prescribing, education looks like within that model of care, and true for benzodiazepines as well. But we really have not talked about what that means with stimulants. So within each setting that's prescribing, I really don't know how they're doing risk mitigation or they're doing any of those things quite yet, because I was actually really surprised to see that. I thought, we can't be unique. This has to be happening elsewhere. And it is happening everywhere. I just don't have a grasp on what it's about yet.
You know, this is Divya. I just can't help but wonder how much of this is also pandemic driven, just purely people are trapped in their homes. They are more quote unquote bored. There's depression. There's all these other things that are coming out. And there is there's a little bit of, well, maybe the issue is because they have ADHD that they're struggling with being able to maintain focus. I don't know. It is really, really interesting. I do worry about overdiagnosing ADHD or actually that being a reason why, to explain that this is why people are resorting to methamphetamines.
Yeah, thanks, Divya. We started to see the increase in 2011. So I don't know, we can totally blame it all on the pandemic. It's been literally almost perfectly an inverse relationship. As opioids started going down, stimulants started going up, and it's roughly the same time frame. I do agree with you that the pandemic has driven it. I also wonder around marijuana legalization, because it does cause symptoms of inattention. And people don't always know that if they're using cannabis, that can cause some inattention. And so when you see that inverse, Rick's laughing because he knows I'm right. So inattention is actually one of the main symptoms if you're using cannabis quite frequently and long term. And it appears, at least in Oregon, and it can't account for the rises in other states, that we had legalization of cannabis happen, and then we also have potentially more people saying that they can't focus or attend, and we have some stimulant prescribing maybe going along with that. And I need to be really fair and truthful to say that's just a hypothesis. I have no data to support that. And I'm just, going to have to dig deeper to see if that correlation if my hypothesis is true.
So you're suggesting that Cheech and Chong films now can be drug education?
Yeah.
And I just want to temper what I was saying earlier. I always like to contradict myself because I'm a good psychotherapist, is that for people with serious ADHD, well diagnosed and worked up, some of these medications can be as close to a miracle drug as we have in psychiatry. So, but like many things, the sloppy diagnosis spreads it out, and it can bite you if that's not truly the issue in front of you. So, okay, any other questions? These are good discussions. Okay.
I am just super grateful for your time and your ongoing support of our work in the community. Thank you so much.
Thank you, Kim.
Okay. And I know we got a run of sit and get here. But the presentation of class standards to the governing board is part of the CCO 2.0 requirements. And so, and Miguel has a great selection of string instruments behind him. So that's a good thing. We will go. You're on.
Thank you so much, and thank you for having us here again with another presentation. So really, this is a great opportunity for us because this is part of our contract to bring this education about the class standards, but it is more than that in this case, because really the idea is to try to get a shared understanding about how to use the class standards as part of our work, of our daily work to advance equity and diversity and inclusion in the region. And so next slide, please. So let me give you a little background about what class standards is. This is basically a national recognized tool that has been alive, I think, for around 10 years now. And in Oregon, it has been widely used as a guiding principle in everything that we do. If you see CCO 2.0 and then you compare to what class standards is proposing, you will see a lot of things that are similar. In fact, in Pacific Source, we have been following this for years as a guiding principle. And in the new contract, it is a part of that. So we want to share with you and find these ways to do it. I've been presenting this for other boards, and some of them decided to include it in a minute, like it is a guiding principle for us. Or then maybe the contract is not clear about what that means. But what is clear is that we need to know and use this opportunity to use this tool for improve our system. So please, by the way, interrupt me anytime to answer any question. So usually the class standards are associated with language access only, but it's much more than that. We will see. So we have already, as I said, already using this at Pacific Source. We have created a Health Equity Advisory Council. We have created even a new value focusing on diversity, equity, and inclusion, and an anti-racism plan, and many others. If you see the TQS, you will find a lot of reference that about class standard. So let's see what is that. Next slide, please. Yeah, so there are 15 in total. So there is a lot of them on the text. Let me send to you a link on the chat where you can click and have an idea. Okay, I think I did it. Oh, Brad, thank you, Brad. So we are working on an anti-racism plan. So for us, it's very important that we are not only trying to avoid that, but we are fighting to eliminate that. And the class standards has been a source of inspiration for us, yes. So it is not finished, we are working on that, but we have that in our plans. So the national class standards, there are 15. The important one is the standard number 1. Oh, by the way, what I'm going to share with you is the easy reading version for the class standards. The class standards are beautiful and very well written, but this is easier to just memorize and use. So the class standard number 1 is the guidance one, and then they are divided in three different categories or parts. And that is where the power of this tool becomes visible for us. So the standards number 2 to 4 really deal with governance, leadership, and workforce. And you will find there that in this part, there are many good ideas about how to advance this area. And by the way, when you navigate on the tool that the Think Cultural Health organization has put together about the class standards, you can check. They have a very rich on the webpage. They have a very rich resource of tools, ideas, activities, and obviously because this is a national tool, there are many other organizations that are using this to advance equity on their regions, and they are sharing research. So a lot of articles. So if you need ideas for advancing whatever one of these standards, it's sure that we can find that on the webpage. Okay, so standards number 2 to 4, governance, leadership, and workforce. 5 to 8, it is around communications and language assistance. And number 9 to 15, which is several of them, it's about engagement, continuous improvement, and accountability. And this second section has many interesting ones that we can explore together now. So next slide, please. Yeah. So thank you. So standards 2 to 4, if you see one aspect that I know you have been working a lot is about how to have a diverse governance, but not only that, leadership and staff that promote classes with the policies, practices, and resources. This is super interesting. It gives us a lot of ideas why this is important, that at the table where decisions are made, you have this representation of the diverse minorities that are in the region. And I know you are very worried about that and put a lot of efforts to try to advance this. So kudos for that. The number 3 is about how to recruit and support leaders that are responsive to or representative of the diversity in the community. And number 4, yeah, it's about training on diversity, equity, and inclusion, and particularly on class standards. Next slide, please. Standards then 5 to 8, really, this is the part about communications and language assistance. And in these ones, sometimes we have made a lot of effort and work to advance these particular standards. Luckily, CCO 2.0 is offering us the support to really advance that in a more consistent way. The health equity plan that Pacific Source built last year is a proof of that, but we have a lot of challenges. How to inform the members that language support is free and available, how to get to them in a way that they need it with plain language, clear language. So those are some examples. And unfortunately, we are seeing the challenges around that and how difficult it is for us to solve the problems when they appear. And an example of that is the actual COVID crisis, when we know that minorities, particularly in the case in our region, Latinos are suffering a lot, right, with this problem. And when we have COVID there, and we have to plan about how to get the vaccines, so then we see how important are these series of standards, because the way to communicate with our minorities is a challenge. And for example, the Gorge, which is similar to us, has recently came to a solution or to an option to create a specific job and specific position to act as a liaison between the community and the needs of the Latinos. So this person is going to be in charge of organizing the information, connecting with the members or with people to answer questions and give them support about where to go, when is the right time to go, what kind of information is needed, etc. So the Gorge board is offering that right now. That's a fantastic idea, if you ask me. Next slide, please. So the other standards, 9 to 5, they are on the category of engagement, continuous improvement, and accountability. And they are divided in two slides because there are too many. And give me the next slide because I want to keep time for you to work together. Yeah, the next slide, please. No, the one before, sorry. Yes, so 9 to 15, it is about how to communicate and how to work together with community partners, how to find the ways to share power with those community partners, with those stakeholders that represent these minorities in a way that the accountability is improved, the way that trust is built with this continuous work. That is something that we absolutely need. And it's about sharing power. So all this, the rest of the standards talk about that, share progress and challenges with the community and the ability to work collaboratively with the community partners. So let's jump into some example. Next slide, please. To how this could be used. And I took one example that you know very well, just to show you how this body can use the class standards and how important they are to help us think about this. So I choose standard number 3, which is about recruit and support leaders that are responsive to the diverse communities they serve. And if I imagine a vision, like ensure that the region has resources to support the development of workforce diversity. And something that you are already doing is invest and create funding to precisely advance the pipeline initiatives that they are. So this is something that you are already doing. And so I want you to invite you, next slide, please, to use this either in a discussion. I don't know if we're planning to do small groups on if it's possible to do it on Zoom, to have some time for discussion on small groups, or if you wanted to do it together. So my invitation is that we choose one of the 15 class, just to practice, to see, okay, let me see how can I use this to advance areas that we are not seeing right now. One example I just shared with you a few moments ago was the example of COVID and the need to create a system that helps minorities to get information in the way they need. That is something that is that we have the problem right now, right? But you can choose any other class that you want. So just tell me, do we have this ability to create groups, or do we want to?
Miguel, it's probably better if we had advance notice that that's where we were going. And so I don't necessarily want to try to just rush something without some previous planning. So why don't you just continue with the rest of your presentation?
Well, that is the presentation, Rick. So the idea in this case is just to bring education about what class standard is, how this can be used as a tool to advance equity, diversity, and inclusion, and share with you the need that we have to, if possible, take this as a tool this body and for our system. So this is the purpose of my presentation. It's just education about that and share with you how Pacific Source is using this. Yes.
Okay, and we could do this exercise all together. That's, you know,
Yeah.
as long as it is relatively brief, I think that'll work just fine.
Thank you. So yeah, let's do it. So 15 class standards. Do you think there is one that we can take? Any suggestions?
Miguel, just knowing this group, I suggest that you suggest it. Or Brad might have an idea since he can be, he's sitting on the board.
How about if I raise, I'd like to share something that came out of some work we did with Oregon Health Sciences University's Center for Children and Youth with Special Health Needs. Did a research project over the last year with our Latino families here in Central Oregon who are parents of children with special health needs. And what came out of that was, number one, they were super grateful to have OHP, Oregon Health Plan, and because their children clearly have more needs than the average child. And these are kids, some kids that can't speak, can't move, are very dependent on their parents because of their health. And so that was the most positive. The other, the negative aspect here in Central Oregon specifically was, and there was a huge contrast between getting services here in Central Oregon and going to Portland. Their experience in Portland was very positive. And clearly those providers, like at Dornbeckers and different places, they have way more experience serving diverse families and patients. But here in Central Oregon, it was very common for those parents to express disappointment with the interpretation, number one, and then just a general language interpretation, and then a general kind of sense that they weren't listened to as parents of their children, that the doctors and or nurses weren't really listening to what they were saying, their opinions of their child and their kind of intuition, so to speak. And that they were also, not in every case, but in several cases, that they just walking into the provider's office, they would see looks on the face of either the frontline secretary or receptionist and or the first nurse or care provider that they would face. They would see on their face that they were like, oh crap, we gotta serve this family that needs language interpretation, and it's going to be hard to communicate, and just kind of an overall body language reaction that they weren't really very happy to see them. And so I don't know, Miguel, if something jumps out to you in these class standards that relates to that.
Absolutely, Brad. And you remind me the first time I went to see my doctor in Central Oregon. So I got to make my first appointment, and the person of one Central Oregon institution told me right up front. I said, "Good morning," and instead of even responding "Good morning," she told me, "We don't take Medicaid people here." So I said, "Okay, thank you so much. I have Pacific Source Insurance," and I was lucky. But imagine if you are just a person that goes into a clinic and you have that as an answer. It's very, very hard. So you are touching a question that is that we need to address, right? So standards number, the second category, number 5 to 8. So it's really what you are sharing with you. Can you bring that slide, please? Number 5 to 8. Yes. So if you see this, all of them, you raised several aspects of that. One of that was really number 8, provide easy to understand materials, because even if the doctors are talking with the parents or providing them instructions about the medications or about follow-up, if those instructions are made for other doctors, for a regular person, will be very difficult to follow you. So you have the impression that even if there is good faith, that you are not being listening or you don't have the tools to follow that. And it goes together with the other ones, right? So like how do they know or that I have free language support, or that I have the right to receive the medical assistance in the language that I prefer. The challenge is bigger when you go to people that has, for instance, low literacy level, and besides of that, they have a problem of hearing or inability to talk and use sign language. Really, those are minorities that are even suffering more than that, or mobility impairments, right? So I would suggest we center the discussion around these standards. And
so, Miguel, do you know which healthcare agencies are currently actively working internally on these class standards as part of their processes?
Well, I can share you that one that stands up for many reasons is Mosaic Medical, and also volunteers in medicine that have made a lot of effort on trying to both have people that is bilingual, bicultural among the providers. And in the case of Mosaic Medical, they have even created a dedicated position of a trainer of interpreters. So the bilingual staff that is part of Mosaic, they have continuous training to become interpreters, and that training is valid to get the certification and the accreditation. So that is a fantastic effort. It's a formula that can be replicated in other areas, because to have an interpreter that comes from outside, or to use that by phone, it's a challenge on itself, because so to have it one inside of the organization, that is what eventually Mosaic is going to create. They are creating their own personnel that has medical interpretation qualifications. That's outstanding for me. I don't know other examples of that in the region yet. Outside the region, outside Central Oregon, yes, there are other like that in the Gorge particularly.
One question that occurred to me is under the governance, leadership, and workforce piece, when you talked about having an organizational policy about diversity and equity and inclusion. And it raises a question for me. We clearly should look at that internally, whether that becomes a part of our policy book that we're working on. But secondarily, maybe doing a survey of providers and organizations, nonprofits, whoever we partner with, to see, is there a prevalence of that kind of policy and leadership at the top? And if there's not a good body of people that are on that page, then what can we do about it from a leadership perspective?
Linda, I think, yes, that is the idea of the class standards, because that helps us, right? And if you cross these with other tools that you are using, like these ones about changes of water, that I see that's a tool that you are using too. So you see that how important is to have the policies, how important is to write the right practices, and how important is to really make sure that the mind is changing to do that in automatic. But because we are not there, so the policies is the right way to do it, right? And you have the ability to do that and suggest that and advance that. Yes, Linda.
So I think maybe a better use for this committee, and I'm exploring this. So let's I may be going off on the wrong direction here, but and Leslie, you may be able to help me with your broader perspective that you see, but just to follow up on Linda's suggestion, would it make sense and not step on something that Pacific Source is already doing themselves, is to survey the healthcare settings across Central Oregon about their adoption of class standards and processes internally. Is that something that Pacific Source already does and that would just be redundant, or would that be using the bully pulpit of the Health Council to support this? Miguel or Leslie, either one.
I think Miguel might have more personal insight here. I know that we're doing some things. I don't know if it's that targeted or specific.
So thank you, Leslie. So the assessment is it's in our plan, and we are gonna conduct an assessment about all the linguistic needs in the region, and this is part of our language access plan, and this year is gonna be completed. So we come back with results. So yes, and precisely what you said, Rick, how to work together is the reason of my presentation here. I'm going to reproduce or make a similar one, a different format for the CAC and also for the providers, just to make sure that everybody knows and understand the importance of class standards. And but your benediction, it will be so important that you approve that and integrate that as a working framework for the region. That would be so good for us.
Yeah, so I would fully support us figuring that out and how to do that in a meaningful way. I mean, I think we need to have some discussions between board meetings to sort of make sure that we're doing that in a useful manner. But I think certainly as a principle, I think that's correct. We've got to get our act together around how to support this. But I think these are obvious federal standards. They've been around a while. They're not new. And they should be embedded into what we do. Donna, do you have any thoughts about that? Am I just barking up the wrong tree? Or
No, totally. I just think that, we have our Central Oregon Diversity, Equity, and Inclusion work group or committee, not a work group, but a committee. And I think that we could take information from here, and of course Miguel sits in that space, and that we could actually bring something back to the board to react to on what they would want to endorse coming from this body. How does that sound?
Right, and what I would encourage, and please board members beat me up if I'm totally going in the wrong direction, but what I would encourage is that what we don't do is issue a nice politically correct statement that does nothing, right? Sort of bored with that. And so that there's actually an action plan that makes sense to move the dial, maybe not create a revolution, but actually keep moving us in the right direction as a region. So,
and I think that would also be reflected in our strategic plan, Rick. So it's all, we're on it.
So any feedback from the board? I don't actually have any power. I just run a meeting. So any other feedback, Brad?
This could be something that the Community Advisory Council works on and provides the board with recommendations.
Okay, good.
That's one idea.
Any other board members? Okay, silence is assent. Brad.
One other thing that I want to bring up is what systems of accountability currently exist for, because I've heard 2 or 3 stories recently over the years that of medical experiences where the client, consumer, patient believed that because of poor care, because of poor understanding, because of poor treatment, and they believed in these cases that it was based on race and ethnicity, etc. That there was actually a really bad medical outcome, as you know, one baby dying, for example, misdiagnosis or lack of diagnosis for several years. Most recently, that was one of the stories. Was, you know, the mother kind of had an intuition about their child with special needs and suggested things, and and felt like at least the provider just ignored her. And 2-3 years down the road, all of a sudden the diagnosis hits for what she was suggesting. So anyways, my point is there already a system in place at Pacific Source or in our medical system, health system, for accountability to be addressed, where a consumer believes that they received care that was so poor that there was a significant, seriously negative outcome? And I see it as related to this because in the case where it's, poor care related to a person's ethnicity or other.
So Leslie, you want to answer that?
I mean, as far as I know, we don't have any formal process for something like that, but doesn't mean that, someone can't call and either make a grievance or complaint, but also elevate that to our medical director or our chief medical officer. I mean, those folks are always very readily available to talk to anyone about something like that. I'm happy to follow up with you offline if you think that would be useful on these particular cases, and then also happy to bring that to our executive team and talk about if there is a formal process or anything that might mirror something like that. I'm not sure that the grievance process is quite enough there, but I'm happy to follow up.
Yeah, so I think my guess, Brad, and we don't have a hospital representative right now, but and Divya might be able to chime in, but I think all the healthcare process organizations do have a grievance and complaint process. The question really is not, is there a process, but is it working? Is it functional for the population you're speaking to? It might be functional for someone like me who's upper middle class, well-educated, white, and bossy, and I can get further in a system, but even I can find those systems to be very difficult. And I'm willing to fire doctors. Whereas if you don't have all those advantages, that may be a very different experience. And so I think the question before us is not that, is there a system, but is it a is a functional system for the people you're talking about? And it's not just Latinos and Native Americans, but also, as you spoke to earlier, people with disabilities, people who are struggling in other ways.
Yeah.
So I think that's a really, really core question.
And I would agree, Rick. If we have a system, a grievance process or whatever, if we don't have a way of collecting data or asking the question about, is this in your complaint or your grievance, do you feel there was an equity component to it, or a racial component, or a gender component, whatever the inequitable part is? If we don't ask the question or allow ourselves to collect data about that, how do we know how big of a problem it is?
Yeah, Linda and Brad and members, during last year when Pacific Source was preparing the health equity plan, we conducted listening sessions in all the regions with community partners, members, and some of them in Spanish. Thank you, LCA, for organizing those in Spanish only. And what Brad just shared, and you are talking, it was one of the main concerns. People felt like even if they complain, they don't, the follow-up is not optimal, and there are so many barriers related to fear, uncomfort, and lack of knowledge of the process, etc., that it's worth it to review that entire process. Now, Brad, I want to share with you that the state just recently augmented the number of ombudsman on the state. When everything falls apart and there is no answer from the hospitals or the CCOs, there is another option that is ready to take those complaints to another level. I will find the right link and share with Michaela or with someone to make it available to you.
I want to, Commissioner Dare, you took yourself off mute. Did you have something?
I have something even beyond this. I had been told by one of my physician friends that doctors really with COVID have really, a lot of doctors have changed how they actually present medicine. You know, we've had a lot of telemedicine. Well, I actually went to see a doctor in person, my endocrinologist, because I've always had a thyroid issue, and went to him the other day. And that man never came across the room ever and checked to make sure that I could still swallow and I didn't have any like problems developing. And it was really quite fascinating. I kept thinking, oh my gosh, I'm actually made the effort to go to my doctor. I've been doing the same annual appointment for decades. And that doctor was so apprehensive about like getting close to me. And yet, okay, I can go to my facialist and she works on my face and I don't have a mask on. So I'm thinking, okay, I understand when you have a language barrier, but you know, what a horrible thing to say to somebody. Oh, if you're in Medicare, I'm not going to treat you. My husband treated all kinds of people. He had medical Spanish, as he calls it. He was pretty good at that. But, you know, I just feel like I believe there are a lot of doctors out there today in today's world and maybe going forward that are going to really be a bit more apprehensive about actually being close to the people that they're supposed to be treating. And a lot of times doctors can learn a lot by seeing someone's eyes and what's actually on their face. What you say or what you check off is not always the same thing. And I feel like, you know, medicine, I don't know how we can take medicine back a bit to, you know, actually Marcus Welby.
Yeah, and I had dental surgery last week, and that was lots of spit and everything around, and they did that just fine. So, yeah, some of this is a head scratcher. Okay, we're running out of time.
Thank you so much for having us. We really appreciate the time. We
have some action plans coming out of this that we want to percolate on in the next month and bring back to the board for next month, possibly, ideally.
Thank you. Bye.
Okay, thank you very much. So the last thing is the cost and use steering committee report out. And so I'm going to seek help from Leslie and Divya. Are you in a ditch yet, or are you still able to talk to us? Okay, she may be in a ditch.
Oh my God, stop jinxing her. Jeez.
What are you doing driving across the pass today anyways? So it'll be Leslie and I. As we've talked about in the budget, there's a concern about long-term trends in specifically some specific areas in the budget. And when we met, we initially identified 3 parts to really focus on. One was behavioral health, second was orthopedics, and third was
Hospice care.
issues with the contract and the model of the contract. After some, initially we formed a broad cost and use steering committee that answers to the finance committee. And so we now have, so the contract issue went to the contract committee and actually resulted in some changes in the contract in the, with the hospital and that were meaningful, and we're tracking that. Then the behavioral health and orthopedics, where that has gone is Pacific Source. Dr. Franz had developed a, I think 4 or 5 point plan to address the issues. What we found was it was a pretty dramatic, rapid rise in one billing code amongst panel providers was really the place where Pacific Source thought had the place to focus on the most. They've developed a detailed plan with that they're implementing, and we're asking for quarterly reporting out on that to the CUST. And then Dr. Sharma and Pacific Source have met with orthopedics and working on their cost of care issues, which I don't frankly understand. And so again, we're looking at quarterly reporting out on that. Leslie, am I missing something?
I think that, so we're also circling up after we met with the chair, with Rick and Divya and Donna, our chief medical officer and business intelligence VP and many others are working on a plan to present around some 2021 cost levers that we'll be drafting up for folks to react to.
Right, and so the discussion was that if there is, what we don't want as a governing board is stick the Pacific Source out, and we're concerned with cost drivers. We don't want them to get painted into the corner of being the big mean insurance company that's beating up on the poor healthcare system, but that that this is a community process that we will support. So, because sometimes when you really begin to address this stuff, there's some pain involved. So we want to be able to bring that out and support that, because that's what we're asking for, is really actions that can control those costs. Questions? Anything else, Leslie? Okay. Questions?
I don't think so. I think we, just timeline wise, I think our next kind of check-in is end of February. Is that right, Donna?
Yep.
Questions? Okay. That's it. Any other questions or concerns for the board? Because we're done. So can I hear a motion to adjourn? I'm reading lips, and Eric said yes. Very seconded.
Second.
Okay. All in favor, say aye.
Aye.
Bye.
Thanks, Rick. Thanks, everybody. Be safe out there.
All right.
Stay warm.